Good morning, and thank you so much for attending the second annual State of Coverage Policy Forum put on by Covering Kids and Families of Indiana. I was hoping that we could be together physically today, and mostly because our keynote speaker has never been to Indiana. Seems we're sending lots of Hoosiers to DC these days, but not so many the other direction. It so happened that because of the public health emergency and all that has been going on with the COVID numbers, we decided to flip the switch and make this a virtual event. The in-person event would have had limited seating, but there would have been a lot of chances for us to network and to see each other, since we haven't lately. It was very hesitant to flip that switch to virtual, but want to thank you all, because since doing that, we have moved from having about 40 people interested in coming to the event to over almost 200 people that are registered and with us this morning. I'm so grateful that you've chosen to be with us. I was really worried about moving to the virtual venue because I was afraid it would stifle the message and weaken the urgency of this topic. We picked the title last year, Disparities from Coverage to Care. Although we picked that last year, the timing is critical right this minute. This gathering informs and becomes the focus of our CKF policy initiatives for the next year. If you were with us last year, you'll remember that the focus was on children's Medicaid and the health care issues affecting children. Shout out to our CKF Policy Director, Mark Fairchild, and all of those who serve on the CKF Policy Committee. There have been substantial movement in the areas of children's health since we were last together. Now, some housekeeping and some agenda items for you. We're going to be using the chat feature for you to ask questions of the keynote speaker and all of our learned panelists. Feel free to type comments in at any time, and we will get to as many of those as possible. You may have heard at the beginning of this session that we are recording it. That is true, but none of the participants, so none of you, will be visible during the session, and only the panelists can see comments. So feel free to be yourself and say what you mean and say what you want in the chat. So after Cara's presentation, we're going to move to a panel discussion that will include her, but also some leading experts on health disparities from Indiana. We have a jam-packed, wonderful agenda for you. So sit back, relax, and let me introduce you to our keynote speaker. So I told Cara that it would take a long time for me to take almost the entire event to tell you all the things that she has accomplished. She is an awesome woman, and we're so grateful to have her. I want to tell you how we found her. I was talking with my good friend, Penny Duckham, who works at Kaiser, and this was last year, right after the session that we'd had last year, and I told her what we had picked as our topic for this year. And before I could get out the full name of the title of this session, she spoken to me, and you got to get Cara, James, you got to. And I said, okay. So I immediately hit LinkedIn and asked her to friend me, and she did. And I wrote her a really long email, and I didn't even scare her off. She responded, and now she has not only accepted my friend request on LinkedIn, but she's agreed to be here with us today to speak. No further ado, very glad to have you. Please welcome Cara James.
Thank you so much, Susan Jo. It's great to join you all this morning. And as Susan said, I am sorry that it could not be in person, as I would love to make it to Indiana. I have not visited that state just yet. So today I wanted to talk about some of the opportunities to advance health equity through better coverage. And as Susan Jo mentioned, it is a really important topic, particularly at the moment in which we find ourselves in our country. And coverage is such an important piece of people's health and access to the services not just from a healthcare perspective, but also to preventive services that can keep people healthier longer. And as Susan Jo mentioned, I was at the Centers for Medicare and Medicaid Services, and so I would be remiss if I didn't take a moment right now to let all of you know that it is Medicare open enrollment. And while we are here today, particularly talking about kids and families, we know that our older adults are important members of our family, and in some cases, they are the primary caregivers for the kids that we're focusing on. So Medicare open enrollment is now, it ends December 7th, and it's a great time to review plans and make sure that they're meeting your needs. So today, I've been asked to kind of boil down and talk about health disparities and the importance of coverage. And I'm going to do this as quickly as I can. So I hope everybody is caffeinated and ready to go. I'm going to take a little bit of time just to provide an intro, Grantmakers in Health and who we are and what we do, and then talk about disparities overall in terms of outcomes, disparities in access and coverage, some particular disparities related to what we are seeing with COVID-19, as well as rural health disparities, and then talk about some of the drivers of those disparities and end with a little bit of what it takes to achieve health equity before we begin the panel. So I work for Grantmakers in Health, and we are an organization that is composed of about 240 funding partners. So these are foundations and corporate giving programs, as well as philanthropy serving organizations across 38 states. It includes 4 foundations in Indiana, including one right there in Indianapolis. And as you can see, we work across a number of areas to help foundations and organizations learn, connect, and grow with the ultimate role of trying to achieve better health through better philanthropy. We focus on health equity, and that's an area we've been doing for years. I am relatively new to the organization, but as I said, that work has been ongoing for years. So what are disparities and what are we talking about? So the Institute of Medicine years ago produced Unequal Treatment, which was a report that really comprised all of the information that we knew related to disparities at that point in time in healthcare. And as you can see, at their core, disparities are differences, but they're differences that are related to things that should not be happening. So those could include things such as the operation of the healthcare system and the legal and regulatory climate, as well as things related to discrimination and bias and stereotyping. As you can see, when we think about clinical appropriateness and patient preferences, those are not part of what we consider to be disparities, although they may be contributing to those differences. However, I would say that we do know that patients who are people of color, as well as those who are low income, report that they do not receive as much information as they would like, and that that information can impact the preferences and the choices that they make. So while not in general do we want to include patient preferences as part of those disparities, there is some fact in which the patient preferences are malleable, and we need to be mindful of whether or not they have the information that they need to make the decision that is best for them. There are a number of different types of disparities. I'm going to focus today primarily on those racial and ethnic disparities, but there are sex disparities, disparities by socioeconomic status, disability, and we have a panelist who can speak to some of those more eloquently than I can, as well as geographic disparities, disparities by sexual orientation and gender status, and other characteristics. So we want to be precise in our language and what we're talking about, because I think somewhat, as we've seen more people coming into this space, language has gotten a little muddled, and we want to make sure we know clearly and articulate what we're talking about. So as I said, today I'm going to focus primarily on racial and ethnic disparities, and I'm also going to talk a little bit about some of those geographic disparities when we look at rural communities. So why are these things important beyond the fact that we shouldn't have them? Well, we are a very diverse country, and as you can see in the US, we're talking about 328 million people, the majority of whom are non-Hispanic white, but we can see that our largest population of non-white individuals is Hispanic, followed by African Americans and Black, and we have Asians And within that, there's a lot of diversity within each of these categories. And so that has implications for different health outcomes, access to care, and quality. Within Indiana, we see that the population is not quite as diverse as the US, but it doesn't mean there isn't diversity there. And as you can see in Indiana, 78% of the population identifies itself as non-Hispanic white, with 10% identifying as Black and 7% Hispanic. I will note that these demographics look similar to what we see for our Medicare population, as well as the demographics that we see overall in rural communities across the US. Our younger population of kids who are under the age of 18 is much more like what we see for the US population overall. And we know that among the kids born today, more than half of them are people of color. So we're growing in our diversity. As we grow more in our diversity, the disparities that we are talking about have real cost consequences. And as the population becomes more diverse, if we don't address these disparities, the costs are becoming more unsustainable to our healthcare system. So in addition to a moral imperative, there's a financial incentive for us to address the challenges that we see. So I'm going to go through a quick bit of some of the disparities, and I don't have time to go through all of them. We could spend all day. I actually used to teach a summer course at Howard University talking about some of the disparities, but we start and just show, when we look at the leading causes of death, we know that African Americans in particular have a higher mortality rate than non-Hispanic whites, and similarly for American Indians and Alaska Natives. As you can see, heart disease and cancer are the top two leading causes of death for all populations, but we get to see a little bit of variation when you look below that. So as you can see for white individuals, chronic lower respiratory disease is number 3, and that does not appear among the top 5 for any of the other populations. Similarly, diabetes is in the top 5 for Black, American Indian, Alaska Native, Asian, Pacific Islander, and Hispanics, but is not among the top 5 or 6 for non-Hispanic whites. And I would lastly just point out at number 5 for American Indians and Alaska Natives is chronic liver disease and cirrhosis. So what the challenges are vary in each population, but it is important to note that everybody has challenges. As an example of some of the variability that we see more specifically, I use infant mortality as an example. And here you can see African Americans and American Indians and Alaska Natives have the highest rate of infant mortality compared to other populations. And there's also, as I mentioned earlier, a lot of diversity within the populations. You can see for the Hispanic population and some of that variability, infant mortality rates are highest among Puerto Rican mothers and lowest for those who are from Central and South America. And just as an example of how the US compares to other countries, when we look at infant mortality rates, you can see that among the Organization of Economic Cooperation and Development countries, that the US ranks pretty low in terms of its infant mortality. And that red arrow even further to the right reflects where the infant mortality rate is for Black and Native American women in the US. And as you can see, it's lower than some of those, higher for the infant mortality rate than some non-OECD countries. So despite having one of the most expensive healthcare systems in the world, we don't have the best outcomes. And for our people of color, it's even worse compared to others. So when we're talking about kids and families, I think one of the examples I just want to lift up is asthma. Very poor health when we're talking about as just an indicator of overall health outcomes. It's a measure that is really indicative of a lot that happens in our healthcare system. And as you can see, we have large variability across different racial and ethnic populations. Among kids, as we look at those with current asthma, we're fairly familiar with higher asthma rates among those who are Black. As you can see, though, the current asthma rates are also pretty high for those who are American Indian and Alaska Native, and those who are two or more races. Obesity rates among our children also is higher for those who are Black and Hispanic. And as you can see, the disparity is a little bit narrower between those who are non-Hispanic white. One of the other things to note for those of you who are on it, you'll notice we've lost a couple of groups. And this is one of the challenges of doing work in disparities. We don't always have great data or insight into certain populations. So you will see that we're missing the obesity rate for American Indians and Alaska Natives, as well as those who are Native Hawaiian or the Pacific Islander and two or more races. But given some of the other indicators, I would imagine that the obesity rate among children who are American Indian and Alaska Natives is similar to that for Black and Hispanic children. We also look at those who have serious emotional and behavioral issues, and we can see that for those children who are between the ages of 5 and 17, this is one where we have a narrower disparity, and we have parity actually, where Black, white, American Indian, Alaska Native children have similar rates of experiencing serious emotional and behavioral difficulties, but those who are two or more races have a significantly higher percentage. Among all adults and individuals, when we look at the suicide rate within our country, this is one where we see where non-Hispanic whites have worse outcomes than all other populations. So we don't always have the case where being white is better in terms of health outcomes, and I wanted to lift this one up, particularly as it has real implications for what we're seeing happening now in our country with higher rates and increases related to a number of issues. So when we think about access to care and getting the needed services, this is just one indicator when we're looking at the receipt of the recommended 7 vaccine series for children, which includes a variety of things such as diphtheria, and tetanus, and pertussis, and others. But you can see that rates are highest among those children, infants who are white, Asian, as well as high rates for those who are Hispanic, and rates that are lowest for Black, American Indian, Alaska Native, Native Hawaiian, and other Pacific Islander. So that's one, and we look at and think about those disparities starting at a very young age, which have implications as they grow up into adults and even later adolescents and teens. And we also think about overall, this is for all, regardless of age, so this comes from our medical expenditure panel survey. You can see that Black, Asians, and Hispanics report more difficulty accessing needed care for an injury or a condition. And when we look at visits to the emergency department for children, you can see that American Indian, Alaska Native children have the highest rate of having at least one visit to the emergency department in the past year. And also similar pattern when you look at those who had multiple visits in the past year. And we know that people who have a usual source of care are more likely to get preventive services. They're more likely to have illnesses diagnosed at an earlier stage. And yet you can see that we have large portions, more than half of the American Indian Alaska Native population, who report the ER or clinic as their usual source of care, making it much harder to have that continuity of care and consistency and develop those relationships with providers, which are really important for long-term health outcomes and meeting those health goals. One other thing to note is I've shown a lot of national data, and we know that all things are vary, and it matters where you live. And so even at the state level, there are a number of disparities, and I know that our panelists are going to talk a little bit more about specifically what's happening in Indiana. But I wanted to just highlight one example of what, even within states, and we look at those counties and how they can vary. This data is from a tool that we developed when I was at CMS, our Mapping Medicare Disparities tool, and shows you the prevalence of diabetes in one county outside of, well, all of the counties, but I lifted up the data for Prince George's County, which is right outside of DC, and is really an affluent county for Blacks who live there. But even within that county where there's higher rates of higher income status among those individuals, you can see that there's a 12 percentage point difference in diabetes between Black Medicare beneficiaries in Prince George's County and white Medicare beneficiaries. So even at that local level, and even when you look down, there's a lot of variability across the states and in the counties. So one of the things that we know is health coverage is so important in terms of being able to get care, to get preventive services, to get treatment. And the type of care coverage that you have also matters. As we know that payment to providers varies based on the type of coverage that people have. And as you can see, 3/4 of white and Asian adults have private coverage. And you can see that at lowest, 37% of American Indians, Alaska Natives, and 45% of Hispanics have private coverage. Medicaid is critically important for people of color, and particularly for Black, Hispanic, and American Indians and Alaska Natives. And as you can see, 1/3 of the population of each of those is covered by Medicaid. And where we have larger percentages for Hispanic and American Indian and Alaska Natives who are uninsured. The data for Native Hawaiian and other Pacific Islanders on the private insurance is not reported just because it's such a small population that the data is not reliable at that point, but you can kind of do the math to see where they are. So one of the other things, and just to highlight, going back to our asthma example for a moment, the asthma rates among those children by coverage type. And so you can see that for Medicaid, there's a higher percentage. It's not a huge difference, but a higher percentage of children on Medicaid have current asthma compared to those who with private insurance, and lower rates for those who are uninsured. I don't necessarily think that the lower rates for those who are uninsured is reflective of the real indicator, in part because it may be an underdiagnosis because they are uninsured and have not gone to seek care. So I just lift that up and note that one of the things that we think about in the importance of coverage and measures that we're thinking to contain costs, in some cases, additional costs may be appropriate and may be reflective of the actual care that is needed rather than indicators of waste or overtreatment. So within the world of COVID, we have learned so much around disparities that have been lifted up. I could, again, spend all day going through the disparities that we hear about and we've learned about, but we know that particularly African Americans and Hispanics have had higher rates of diagnosis, hospitalization, and mortality. They've also had lower rates of access to personal protective equipment. We're seeing that in nursing homes. A recent study just showed that nursing homes with a higher percentage of individuals who are Black or Hispanic tend to have higher death rates. In some states, we've seen that the location of testing facilities, despite the earlier statistics of higher cases and hospitalizations and mortality, that Black and Hispanic communities have lower rates of testing facilities that are located there, making it, meaning that they have to travel further to access those. We also know that Black and Hispanic individuals are more likely to be among our essential workers, those who are lower income and our food service, transportation workers, and others, and have had a higher unemployment rate in terms of losing the rate going higher for them during the course of the pandemic. So those jobs that were lost disproportionately affected Black and Hispanic individuals. They are also more likely to be food insecure. That is not something that was not uncommon before the pandemic, but at this time compiled with the unemployment rates and other loss of income is really having a toll. And lastly, as we come back to our children and what this means, we've already seen for particularly Black and brown kids, but also those in rural communities. In the spring, we had lower rates of participation in virtual education. And you think about what it means for those in rural areas, we talk about a lack of broadband, but we also know that for households in which the parents' education is that is less than high school diploma, they also are less likely to have broadband. So those children, we've seen some studies thinking about and talking about this as potentially being a lost year. And I would just say that I think we will be lucky if it is a lost year. For some of these kids, particularly those who are in high school, if they become disengaged and drop out, I don't think that they're going to be going back. And for those children who have parents who may be essential workers or not have the technical assistance that they need to be able to participate virtually, I don't know that we're going to be making up the disparities that were already prevalent before we started into the pandemic. So we have a lot of work to do to close the gaps that are being widened during the course of the pandemic, and want to make sure that we're lifting that up. So one of the other things that I really want to highlight is that while the country is really focused on health equity at this moment, and I have never in my career seen as much attention being devoted to these issues, we have had people who've been working on these for a very long time, and yet we have not made much progress. So each year since 2002, the Agency for Healthcare Research and Quality has put forth the National Healthcare Quality and Disparities Report, tracking indicators of quality of care across a number of health and care settings. And as you can see, when we look over time, basically 9 out of 10 of the disparities that they have been tracking since 2000 have remained the same. And I think that part of that is that we need to be intentional about addressing disparities, where I think before we have really taken an approach of if we improve quality for everyone, then we will see a reduction in disparities. And we have improved quality for everyone, but we have not reduced disparities. So we do need to be intentional in our focus of what we're doing to reduce those disparities. So I want to take a moment just to talk about rural health and rural disparities as one of the areas. This is data that came from the CDC's special report that they did on the Morbidity and Mortality Weekly Review series a couple of years ago, in which you see that when we look at excess deaths in areas related to those leading causes of death, again, the heart disease, cancer, and intentional injury, chronic and lower respiratory disease, and stroke, in rural areas, those that are non-metropolitan, there is significantly higher excess death associated in those communities. But we also know that going back to that there is diversity within those rural communities, we still see some disparities. So again, just as a fair poor health indicator, Black, Hispanic, and American Indian Alaska Natives living in rural areas report their health to be fair poor at a higher rate than those who are white. We've also seen the impact of COVID that continues to grow in these communities as they are continuing to be hard hit by that and to struggle, but nearly all counties have at least one confirmed case of COVID and a number of those who have confirmed deaths. And the rural case rate continues to be slightly lower than urban areas, but in some cases is just as high for the incidence. When we look at the income distribution of those who live in rural areas, it is not surprising that we see that Black, Hispanic, and American Indians in rural areas are significantly more likely to be living on less than $25,000. So think about what that means for our ability to pay for health services, food, housing, transportation, all of the things that are important to help individuals stay healthy. And at the other end of the spectrum, we see that 21% and 29% of 21% white and 29% of Asian, Native Hawaiians, and other Pacific Islanders in rural areas are living on $75,000 or more. So those income disparities are important as well. The other thing to note is that where you live matters. And so you can see that as we look at the distribution of different populations across the country, 94% of rural Blacks live in the South. And I'll show you why that matters in a moment. And 60% of rural Hispanics are in the South. And at the other end, we see for American Indians and Alaska Natives, a large portion of them are living in the West. And 37% of rural whites live in the Midwest. And so why I bring that up is because when we look at care, and we continue to hear stories today of rural hospitals that are strained and struggling to deal with COVID. But before the pandemic, we had a number of rural hospital closures that have been happening. Indiana's been fortunate and hasn't had as many, but you can see that a number of those hospital closures are clustered in the South. And again, when you look at where people live and who's been impacted by that. So the blue dots represent the hospitals that are completely closed, and the yellow dots represent those hospitals that have converted to something else. So in Indiana, we had 2 closures, but one of those converted to an urgent care center. So there are still some services that are available in the community. But these hospital closures have disproportionately affected Black and Brown communities in rural areas. So what's causing these disparities? What are the real drivers of what we see in disparities? We talk about those things as the social determinants of health, or where you live, learn, work, and play. And the things like socioeconomic position, income, education, wealth, gender in terms of gender identity and sexual orientation, relationships. We've heard a lot in the pandemic about those who are socially isolated and not having the social support that they need, or the engagement and the impact that that's taken on mental health, but also on access to services and things like that. Race, ethnicity, language, the neighborhood in which you live, as well as other things related to employment and the type of work that individuals may engage in. We have a variety of data. Some we don't have very good data on, or any data at all in some respects, and others we have very good data to measure. So those in green, when we think about dual eligibility or race, ethnicity, urban, rural, and despite the fact that we have a number of definitions for what rural is, we do have the ability to do a good job of using that data to understand what's happening. But at the other end of the spectrum, we don't have very good data collection on sexual orientation and gender identity, other environmental measures that are affecting people's communities, and similarly related to social support or living alone, and how we calculate wealth in terms of being able to understand what's happening. So not surprisingly, when we look at income, and this just shows you the variability, it looks very similar to what you saw for the rural data, with slight variability, slightly lower portions of Black and Hispanics who have incomes less than $25,000. But we see the scale changed a little bit. So the purple in the rural communities reflected 75,000. Here we're talking about 100,000. And as you can see, almost half of Asian Americans have an income of $100,000 or more, compared to 34% of those who are white. We do not have the data from the Census Bureau for the Native Hawaiian, American Indian Alaska Native, nor for Native Hawaiian and other Pacific Islander. When we look at children, you can see that nearly 30% of Black children live in poverty, and a quarter of Hispanic children live in poverty. So making it harder for them to achieve healthy adult status in terms of access to, again, so many things that we have, but also why coverage through Medicaid is so important for these children, because without it, they probably would not have access to services. That translates as well into lifelong poverty and lifelong challenges. So when we look at the median savings for our Medicare beneficiaries, and you think about this and what this means for your ability to age at home, and to stay healthy and make those adjustments if you needed to put up handrails or grab bars, or if you wanted to modify a bathroom. It's very hard to do that on $14,000 if you look at the median savings for Black Medicare beneficiaries, or nearly $10,000 for those who are Hispanic, compared to those who are white and have $117,000, $118,000. So it is not surprising that we see in nursing homes that Black individuals in nursing homes tend to be younger and sicker, because your choices become significantly limited if that's the amount of money that you're working with. Not surprisingly, we see that those who have more income are more likely to have a usual source of care compared to those with less income. But you see that even within each of the income bands, there still remain disparities, with Hispanic individuals being least likely among all of the income categories to report having a usual source of care. Language is also really interesting. We have more than 62 million people who speak a language other than English at home, and more than 25 million who speak English less than very well. So their ability to navigate through the healthcare system, to engage in the education system for their kids, or to work with the judicial system or the other areas in which they may be involved could impact their ability. These are the top 10 most frequently spoken languages at home. And this is quite interesting because when I started making this chart over 10 years ago, you did not see French Creole on the list, nor did you see Arabic on the list. And now you see that French Creole is number 10, and Arabic is not only on the list, but it is now number 8. But we know, again, where you live matters. So when you look at the languages, and this is a lot of information, so I'll take a moment and go through this. This reflects the top 10 languages spoken by Medicare beneficiaries and the proportion of those who are limited English proficiency. So California, Hawaii, New York, and Texas represent the states with the largest proportion of individuals with limited English proficiency. And because we're talking about Indiana today, I added the Indiana data. Indiana is not the lowest state in terms of the percentage of individuals with limited English proficiency, but it's clearly a lot smaller than the leading states. The languages that are circled in red represent languages that are not among the top 10 for the most frequently spoken languages in the US. And so you can see a lot of variability across that. And if we were to drill down into a more local area, such as Indianapolis or another community, you'd see the languages shift even more. So what that means, and then that top bar in terms of the, just below, when we look at the first language, the proportion of the population with limited English proficiency who speaks that language. So in the United States, 52% of Medicare beneficiaries with limited English proficiency speak Spanish, as compared to 84% in Texas, and there in Indiana, as we can see, more in the 40s. Hawaii, not surprisingly, Spanish is not the #1 language, but Ilocano is. So it's quite an interesting map of our communities. And when we think about making sure that we're communicating to people in the language that they prefer, that we're thinking about not just the most frequently spoken languages of the US, but that local nuance and flavor to make sure we're reaching people in a manner that is culturally and linguistically appropriate. So key takeaways before I move on to the what do we do, is that we know that disparities exist in health status, access to care, quality, and health outcomes. And there's still, despite all that we do know, some things we don't know. And we need to continue to improve our data collection and analysis and reporting to make sure that we're not only lifting those up, but we're monitoring our progress as we work to address them. Regardless of how they fare in their aggregate, all racial and ethnic populations have problems. And as you remember to the slide I showed on suicide, where the suicide rates are highest among non-Hispanic whites. So it's not always the case that communities of color are faring worse in their outcomes. The other thing is that racial and ethnic groups are not monolithic, and there's a lot of variability within that. Thinking back to the slide I showed on infant mortality within the Hispanic population. The cost of not addressing disparities is large, and it's apt to get worse. It's been estimated that disparities are costing us upwards of $220 billion in our healthcare system. Much of that is borne not just in terms of the cost to the system, but think about missed school, missed economic and employment opportunities for both the children and the parents who are out of school or out of work to care for an individual. There are many factors aside from race and ethnicity and things that are impacting healthcare that are affecting our disparities. We talked a little bit about some of the social determinants of health. And there are a number of things that people are doing to address disparities, but we still have a ways to go. And I think that the time really is right with so many people who are looking and talking about this, some for the first time, some who are really thinking about how do we push the envelope to make sure that when this window of opportunity closes, we are much further along than we have been. So what can we do? And what does it take to achieve health equity? Well, one of the things, going back to, again, that just common language, making sure we're all talking about the same thing. Healthy People 2020 and 2030 defines health equity as the attainment of the highest level of health for all people. That doesn't mean the same thing for everyone, because we do know that people are different, but the highest level possible. And that we are eliminating disparities. So this graphic is one some of you may have seen. There are a couple of different versions of this. There is the newest one here with the bicycles. And equality would be that we give everybody the same thing and we treat everyone the same way. And that's not really what we're talking about, because as you can see, if you give everyone the same thing, it may not fit their needs and help them to get to their goals. So equity, as you can see in the lower part, is giving people what they need to be able to achieve their outcomes. So the Prevention Institute has provided this kind of framework for thinking about how do we get there. So looking at the equitable distribution of power and resources, healthy community conditions, quality health care, and empowering people to engage in their health and be a partner with their providers and others to make those healthy decisions. When we think about health exposures and behaviors leading to decreased medical conditions, ultimately to achieving health equity. So health equity is a destination. It's where we're trying to go, and it'll take us a little while to get there, but it is possible to do. And in order to do that, we need to think about addressing the challenges that we see at every level of our socioecological model. So not just focusing at the policy level or at the individual level, but working at every level in between with the community, the organizations, and interpersonal. Coverage is clearly an important piece of that. But even when we think about coverage, our coverage has inequities baked into it. We've set up a system for older adults in Medicare. We've set up a system for low-income pregnant women and children in Medicaid. We have a system for those who have a job, which we have seen the challenges of in a crisis where people are losing their jobs. We have a system set up for those who are members of federally recognized tribes. We have a system for those who are incarcerated. We have a system for those who are active military. We have a system for those who are retired military. And we have a system for those who have no access to any of that we call our safety net. Each of those comes with different access to services, different availability, different payment rates to providers, and it has inherently in it a system of inequity. So it is something that at some point in our future of this country, we are going to have to think about and reflect on what that means for our ability to attain equity, because if we don't address some of those, I'm not sure we're actually going to be able to get there. So again, just looking at all of the different ways in which we are building up these disparities, we also have to tackle them at each one of these levels. So to get there, we really need to start by making health equity a priority. For too long, to be frank, we've paid lip service to health equity. If you think about each of the states in our union have a state office of minority health. And one of the questions is, do you know those individuals who work in that office? How many of them work there? What is the budget of their office relative to others? You will find that these are often underfunded and understaffed offices that are also, in many cases, disconnected from the broader conversations that are happening, minimizing the ability of them to actually have an impact. Again, looking back at the National Healthcare Disparities and Quality reports, improving quality alone does not lead to a reduction in disparities. It does likely improve quality, but again, not that reduction in disparities. We need to strengthen the role of leadership. Think about what our leaders talk about, and when what they don't talk about send signals to a lot of people of what they're focused on. And increasing the role of leadership is important at this time, because these are not problems that arose overnight. and they're not problems that we're going to fix in a 30, 60, 90-day plan. So we need long-term sustained support for the work that needs to be done. The other thing is engaging with the communities that we're actually trying to help. We often approach them from the standpoint of we know what is best, and not necessarily from a standpoint where we have things to learn. But the communities that we are trying to help know a lot of what's going on in their community, can talk about how they can, how the solutions that we're proposing could be better adapted to be more successful, and can also help in brainstorming what those solutions should be. The other thing is to support data infrastructure and analysis. We still have gaps in our knowledge, but we also need to do a better job. You think back to the beginning of the pandemic, we did not have insight into data around the disparities that were being exposed through COVID. And it took us a while, and it took until August before we actually had the testing coming in reported by race and ethnicity. So we don't want to have that as we move into the vaccine stage of this, as well as looking at longer term recovery, but even thinking about within our Medicaid program, Medicare, and others, how are we getting insight into the disparities that we have? The other thing to achieve health equity is we have to tackle the tough issues. As I know, a lot of what we see is not the result of things that are happening in a healthcare setting. They're things that are happening outside of a healthcare setting. Tackling those issues really will have a significant impact on our ability to achieve health equity. And we need to make health equity part of standard operating procedures. We are in a moment, and we are in a window of opportunity. The window is going to close, and we're going to move on to something else. But making sure that the health equity efforts are part of standard operating procedures will help to ensure that they continue as we move on and change our focus. And that speaks to creating program and policy sustainability. And lastly, making sure that we have a robust pipeline. I have received innumerable phone calls, emails of people who are looking to diversify their leadership in their organizations, their boards, their whatever the case may be. Disparities work has largely been poorly funded and poorly staffed. And it's hard right now to have the needs being met as so many people are reaching out. But we need to think about our pipeline. If we can't graduate more kids of color out of high school and college, we cannot have the diversity in our workforce, not just from a healthcare perspective, but from the leadership perspective of education, government, business, as well as healthcare that we so desire. So for those who are engaged in this work, some of the things to think about as you're approaching the development of programs and policies, some questions to think about. What are the existing disparities in that area? How might the changes that you're proposing affect the availability of treatment and services for different communities, be it enacting on provider or location or incentives to move or change things? How might it impact the ability and willingness of providers to treat patients? Sometimes the barriers may not be worth it, and if you can, think about how you might change the policies to address the workforce barriers or the distribution and the incentives. The other thing is, what is the impact on the ability to collect and report? Sometimes we put programs in place without an ability to do that monitoring of them that's well, to understand how it's affecting different populations rather than just the overall. And if there's an ability to make sure that there's reporting that's coming out. What resources are needed to implement the policy? What policy changes are not all one size fits all, and it may be the case that in some communities and in some areas there are different things that are needed. Thinking about in rural areas where volume differences make it more expensive to provide services because you don't get those economies of scale. Similarly, for providers who see more Medicaid patients, their reimbursements will be lower for the same services, making it harder to have some of the resources needed to do quality improvements or other activities that could help improve outcomes. And then, have you engaged the communities you seek to help in the work that you're trying to do? Who's represented the community, and have you heard multiple voices, and how are you working with them moving forward? So The one thing I want to close with is this is hard work, but it is possible to reduce disparities. And one of the things that we started when I was at CMS in 2017 was the CMS Health Equity Awards to lift up those who have been able to close the gap in their disparities, to both encourage others in this space to do the same, as well as to provide some support for how they have gone about doing it. And again, to lift up those who are doing this work to show that others outside of the organization care. So these are the winners that we've had in 2018, 2019, and then this past, gosh, it seems like ages ago, February, with Atrium Health and United Healthcare. So they hopefully will be doing it again next year, and would encourage you, if you have programs and initiatives that have been effective in reducing disparities, to consider submitting for that. So with that, I thank you and look forward to the discussions and questions.
Right, we have our panelists starting to join in. So I want to start by thanking Cara for that wonderful presentation. And starting with an apology that there's no possible way we'll cover everything, of course, on that list, but such wonderful stuff for us to really sink into today. I also want to remind all of our attendees, we'll be using the chat feature today for any questions you have for our panel. I'll be monitoring that, and hopefully we can get some good ones in there. I also want to note that as was mentioned in the opener, we are virtual today, of course, but very happy to see that we have about twice as many attendees as we did at our last in-person event. So feedback we'd love to hear from the audience too is this a format that's working for you? And is it actually increasing your ability to participate and be involved? Since we're talking about inclusion and equity today, that seems like a good question to make sure we're asking if this allows a better ability to participate for everybody. So with that, we're going to jump right in with some introductions of our panelists. We have quite a wonderful group today. Of course, Cara is staying on with us as well, so she's not getting away from us just yet. But we'll be going into a little bit of the Indiana perspective, and then, of course, bouncing through what that has to do with the national trends we're seeing as well. So I'll just give quick intros, and our speakers can talk more about themselves as we're getting to the questions. Privileged to have everybody here today. So first, Kosali Simon, she's a health economist and associate vice provost of health sciences at Indiana University. Does a lot of great work about how our different healthcare and health coverage policies impact populations, especially vulnerable populations. Doing a lot of work right now, of course, on COVID and what we're seeing there specifically. We also have Vanessa Summers, Indiana State Representative, and with the Minority Health Coalition, has done a lot of great work, specifically with infant mortality, of course, many other programs that impact all the populations we're talking about today. And have to mention, she is our first African-American to become the Indiana Democratic House Caucus Chair. So always happy to see that, and a great asset to us. So she'll get all the fun questions about what she's going to change for us in the Indiana General Assembly this year. And last and certainly not least, Michelle Trivedi. She's with the ARC of Indiana in the Insurance Advocacy Resource Center. Has done a lot of grassroots stuff around access to coverage and care, specifically with the intellectual and developmental disability community, and a lot of direct service there, but also working on all the good policy stuff to keep it broad and get access simplified and as easy as we possibly can in that realm, which has certainly many of its own unique challenges. So, and again, we'll let them introduce themselves a little bit more as they go through. I will do what I generally forget to do and also introduce myself. I'm Mark Fairchild. I'm the Director of Policy and Communication for Covering Kids and Families. So I do things like set up these, as well as do our government affairs work and work with our stakeholders to make sure that we're all looking at the policies that are out there, expanding those that are working, fixing those that aren't, and increasing access to healthcare, hopefully along the way. So again, I see questions starting to come in the chat. We'll certainly get to those. I'll start with a nice opener, kind of starting up where Cara left off. and that is talking about COVID and specific health disparities we've seen there. So we know COVID has laid bare a lot of disparities, virtually all of which we are aware existed certainly before COVID. But boys have brought a lot to the forefront, right? So looking at that, looking how that's impacted the economic futures of Hoosiers, the health futures, and some of the other things there. Kosali, could you start us off with one particular item that you've really seen brought to the forefront during the pandemic?
Absolutely, and thank you very much, Mark. Thank you, Susan, Joe, and team for putting this event together. And Dr. James, I think you laid really important information for us to have at our fingertips to think about where we go next. So I'm going to focus on COVID-19 and health disparities that have come abundantly to the forefront in Indiana. But first, putting in context the Indiana numbers. So there have been about 170,000 positive cases, and starting even as early as April, it's quite clear that there were racial disparities in these numbers. The Polis Institute reported that Black Indiana residents were more than 2 times likely to be COVID-19 positive. And that's just a start in thinking about where we have the numbers of COVID-19 positivity. Then when we look at hospitalizations, Indiana has had now about 16,000 COVID-19 hospitalizations. There too, when we look at the numbers by race and compare to population numbers in Indiana, we have about 2.5 times more likely than whites for Black residents to have hospitalizations. That number also holds when we look at deaths. There's been about 4,000 deaths, and there too the numbers line up. And so we can see these numbers and see how they've trended and on various dashboards, on the Indiana State Health Department dashboard, on the Reagan Street dashboard, and these show up. So this is quite obvious in bringing to light health disparities. There's lots of other disparities that research in Indiana is showing from surveys of food insecurity. As was mentioned, it's same as nationally in Indiana. Work that has been done by Indiana University researchers have shown in the area of energy insecurity as well. The number of people who have had energy disruptions, utilities disrupted, it's a staggering 15 times higher among the Hispanic population in a report that was recently released of Indiana surveys. And for food insecurity, the percent who have become newly food insecure in Indiana is reported at 3 times more for Black population than the white population. So these are just, whenever we go into any other area too, these numbers are going to be bringing up, of course, the discussions of what we do next.
Great. Do we have any of our other panelists who want to chime in on that specific disparities, maybe you've really seen come forward, or in your own unique work, anything that you've seen really become exacerbated under COVID?
I think that one of the things that we find as the Indiana Minority Health Coalition is that our Hispanic population is struggling with diagnosis, interpretation, tracing, mainly because, and the fact that they live, a lot of them live communally. So if there's one person in the house COVID positive, then there's going to be more than one person in the house that's going to end up COVID positive. And then they're scared to say that they're COVID positive, and they don't want to get a test. So it's a vicious cycle. And then when they do, they cannot understand the person calling them for contact tracing because they're talking in English. And they're not using resources in our counties that have Hispanic coalitions that can easily help with that issue. So I do know that that happens in the Hispanic population. We already know that in the African American population, that we're sicker and that we're dying faster. So, you know, that is a given.
One other thing that I would just add to the conversation, and I know that we got a chat question on the behavioral health side. So we do know that as a result of COVID, a lot of people are pivoting to telehealth and telemedicine. And that is important, but it's not actually being, again, we're still seeing disparities in this because you have to have that technology in your home as we have moved people out of acute care and into the community. So there are some people who are receiving this face-to-face conversation and that they're engaging with care. And there are others who are having just a telephone conversation where you're not getting to visually see someone. And so I think we're going to see some of that. There have been some changes to make that easier for people. The question specifically was talking about mental health in some of our areas, and as people are struggling with behavioral health issues, we are really taxing our mental health services, which already were, you know, not as prevalent as they need to be across the country. When you look at the statistics related to those who have any mental health diagnosis, any mental health illness who are receiving services, we're talking less than half of the population who are actually getting services, and disparities further for those who are people of color. So we still have some challenges. I think some of this is going to trickle down as we continue to learn and see more. We also have data lags, so we don't have great insight into real-time information in a lot of areas where it would be really helpful to know. But I think that unmet need, as we've moved people out of the acute care setting and canceled a lot of the ambulatory care setting career that was happening, I think is going to make it harder. I think there's going to be pent-up demand. We may see some of the implications of that in a year or two.
No, and that's a fantastic point, and especially you know, the point looking at behavioral health too. We hear that a lot. We've certainly seen a lot of growth in telemedicine, but telemedicine and specifically in behavioral health, it's great that the rates are up substantially. But when the rate of use before was sometime around 1 or 2%, saying that it's gone up 300% in use doesn't really sell us that the model's fully taken hold anywhere. But the access question is a very unique one. Because we're just assuming if we get the capacity of providers to provide telemedicine, that we've now solved the access problem. Of course, we know that's very limited. Rural broadband remains a major problem. And health and literacy of healthcare mixing with literacy of technology is tough for a lot of populations that really haven't had to encounter things in that form. And we found in urban areas, they're not excluded from this issue as well. We know a lot of libraries expanded their Wi-Fi signal just so kids could attend school. Schools had to do a lot of different things and even use their buses as signal boosters across the state. So the idea that even in our urban areas, we know that there's an access issue there, reminiscent of the old days where I talked to legislators about how they thought food insecurity didn't exist in rural areas because you just reach out the window and grab an ear of corn, right? Same thing, in urban areas, there might be technology availability, but that's way different than technology access, right? So great points there. Does anybody else want to chime in on things we can do as far as access to what might become an emerging trend in medicine is really telemedicine and telebehavioral health taking hold in our populations that have barriers? How do we see that working, and what are some of the additional barriers that aren't being thought of yet?
I just wanted to make a comment about, to piggyback on what Dr. James was saying, is that in the disability community, especially among people with developmental disabilities, the technology has been a challenge to not only access to healthcare, but also access to education. A lot of special education needs have gone unmet during COVID due to technology access issues, but also you may have multiple children in the home and the student with special needs is not able to work the computer on their own and needs to have a physical presence with them to be able to access services. So we have reports from across the state of many students, you know, basically, like you said, a lost year. They've really gone without significant services because that has been inaccessible. Another thing I wanted to just backtrack a little bit in terms of how COVID has really affected the population with disabilities is during the initial months of COVID, we had several providers and states put policies into place that specifically said that people with certain disabilities, developmental disabilities, would not have access to certain life-saving treatments such as ventilators. And despite protections of the ADA and Affordable Care Act in terms of non-discrimination clause, the Health and Human Services and CMS had to step in and put out guidance letting these providers and states know that that was not acceptable, that was discriminatory, and had to work with them to rework their policies. And that created a lot of fear in our community as well, because we do have those social determinants of health, and some developmental disabilities are also related to other physical conditions, cardiovascular disease, that puts people at much higher risk for contracting COVID and also having a more serious case of COVID. So that was created a lot of fear and uncertainty in the disability community at the beginning of the pandemic, and really did highlight a lot of the existing access issues that went along with that as well.
One other thing I would just lift up in the conversation is we talk about telehealth and telemedicine. We are all extremely fortunate in where we live in our households, but there are a lot of people who are living in really small spaces. And as Vanessa mentioned, people who are lots of people in those small spaces. So when you think about what that means for privacy, to be able to have that conversation with your provider to share, I do have some concern about how much information really is being lifted up and identified in terms of where there may be need. We know also that as we talk about the mental strain and the challenges, the schools play a critical role in helping to be a place where they identify some of those needs that are not being met, and we don't have that happening in a way. So I have concerns about that. And then the last thing is, before all of this started, there were questions about how do you measure the quality of care provided via telemedicine and telehealth. And those questions still remain. So I think trying to understand what is the quality being offered, how is it variable, and what that looks like are still some of those questions that we still have going forward.
Excellent points for sure. And I do want to piggyback on one of Michelle's thoughts, as well as this kind of concept of lost year of care that we're having for a lot of folks, and especially for our children. So some of the stats that the Centers for Medicare and Medicaid Services have put out is when we look at some children's issues, things like preventative and developmental screenings are down by almost half. Outpatient mental health care is down by about half. Immunizations are still down dramatically as well, but particularly one that I always find troubling is when we look at that developmental screening rate in those early preventative screenings. That's where we identify a lot of kids that may have issues that with early intervention can be a lot better off. So a huge downstream impact there, right? I worked with autism intervention myself at a much younger age. I knew if we saw a kiddo at 2 or 3 years old, we had a very good future, and it was a lot tougher when it was even a few years later than that, right? So big missing piece there, coupled with the fact that we know minority children are less likely to be covered by public programs. And actually those in general that are eligible for public programs are less likely to be covered than those under private insurance or that have access to private insurance. So we know our minority populations are already at the bad end of the statistic there, the Hispanic population, but also many other minority groups. So any thoughts on what's going on there? Are we worried about what COVID's going to do to layer upon that, that we see the minority population, the low-income population likely to be missing out on a lot of care for their kids right now?
Maybe I'll start with just talking about health insurance coverage among children and among populations in general, and racial ethnic disparities. So as we know, since the Affordable Care Act, there has been a large reduction in uninsurance And while children's eligibility was not changed by the Affordable Care Act, for example, for Medicaid, children had already received a big lift in health insurance eligibility from the Children's Health Insurance Program of the late 1990s. There is an impact that having the family covered has on children's sign up. Parents are better able to navigate what it means to have health insurance, how to sign up, how to get access to care. So there was an increase also in children's health insurance after the Affordable Care Act. But in the last few years, in the last couple of years at least, there has been an increase in uninsurance among children, particularly in certain populations. When we look in Indiana, for example, uninsurance rates among Hispanic communities is extremely high, and it's double the uninsurance rate for white populations. And so thinking about what is happening during COVID, this is all pre-COVID. We do not really have solid numbers on the COVID period for health insurance because our usual sources of population level health insurance come from the Census Bureau, and those are conducted and released much later. But we know job losses have been unequal across race and ethnic groups. And we know that income and connection to health insurance through jobs is also a really important source of coverage. And so we just know that when we get these numbers, they're not going to look good. They're going to show losses of coverage. And that has further implications during times when there is more uncertainty and instability in access to healthcare services and screening. On top of that, you're going to layer losses of health insurance for vulnerable communities. So I think thinking about the role of safety net programs, strengthening Medicaid during this time period also is an important conversation to have.
And I think one of the other things I think about is when we think about the importance of coverage and some of those protections, we have protections right now on evictions to prevent people from being evicted at this moment in time. But those individuals still have not obtained those jobs. So at some point that is going to come due. And sort of what that means in the disruption of homelessness services, the continuity of care that gets lost as people are displaced. Is something that I think we need to be thinking about longer term to try and figure out how we shore that up and make that less of a cliff that people are going to have when those protections are removed. Because we do know so many things related to homelessness, behavioral health, access to care for those kids, they will be further lost to our systems and our opportunities. So something to really focus on.
Great.
I wanted to comment that I think Dr. James pointed out really well in her presentation as well, as there are a lot of systemic issues in terms of how providers are reimbursed and how insurance networks are set up that also contribute to what I fear is going to be a backlog, a pretty tremendous backlog of children who are waiting to be evaluated and are kind of bottlenecked at the gateway of being able to get those services, not only medical, but also educational, that they may need to really prevent lifelong disability. And that really needs to be a focus in terms of looking at what are some of the outcomes of this crisis that need to be addressed, because that will live with us for a generation if we don't intentionally address it.
Right, and definitely two ends that we're seeing of coverage right now. One, we're getting some people signed up, some of the barriers are reduced, but what happens when all these things end at the end of the public health emergency? Right now it's extended to January. We don't know when that ends. All the things that are keeping people on care. That's going to be a whole population that maybe had an easier on-road. I would argue that they should have had an easier on-road in the first place to care. Maybe it shouldn't have been so difficult in the first place. We like to talk about skin in the game in Indiana, and I think anybody who's filled out a Medicaid application automatically has a lifetime of skin in the game. And Michelle, working with things like autism waivers and everything else, there's no doubt you have skin in the game if you go through that process, which is so difficult there. We also aren't seeing, and this is going to one of our audience questions, we aren't seeing applications really tick up dramatically at all. There's some reporting saying, well, Medicaid rates are up, which is technically true. But the other side of that is they're up largely because people can't be removed from most of those programs at the moment. So we're kind of seeing a false positive there, right? That we have more people than we did before, but that's only because the large amount that typically gets knocked off due to compliance issues and reporting and other things isn't going off, not because more people than usual are signing on for this time of the year. We do see a slight uptick in the Healthy Indiana Plan, our adult Medicaid expansion model, but children's coverage and other ones are still fairly flat, right? So where are we failing there? Because we've got a lot of unemployed people. Measures would say Hoosiers that have lost insurance through their employer are in the hundreds of thousands. Where are they going, and what opportunities are we missing?
I think you're missing a marketing opportunity. They don't know that it's available. And you know, sometimes we ignore that we're sick, and so until it's an emergency situation, we don't seek out to cover ourselves and take the steps that we need to take, unless somebody says, here, A, B, C, D, do this and do it now. Just like nobody is going to the doctor. Nobody, it doesn't matter if it's a child or an adult, that haven't your doctor's been calling saying, when are you coming in? Let's get your physical, you know, all the things that you did not do when COVID first hit, your colonoscopies, your breast exams for women. You know, we're not doing anything. We're not doing them. So if your child is grooving along and they're not seeking help unless it's absolutely necessary to figure that out. But then they don't know where to go or how to go. So I'm going to say marketing campaign would be something that would help at this time.
I would agree with that. I think the other thing that I would layer in there as part of that marketing campaign is, you know, how to apply, where to apply, how easy it is.
Oh yeah, that's all.
And, you know, the importance as well. I think one of the other things when we talk about people who've lost their jobs, people who are food insecure, people who are housing insecure, the fear of a copay, if there is one associated, is going to prevent a lot of people from going in and seeking care. So to the extent that these programs are covering those services and copays to allow that to be something that is a lot cheaper for that individual will help. But I think, you know, for the people who are living paycheck to paycheck and have lost a paycheck or had a paycheck cut in half, even a $5 copay for something can be something that is a deterrent from them from seeking services that are needed.
I think also what's factoring into some of that is just being in a crisis, getting through the day is everybody's number one priority. And if you're on the phone for hours trying to get your unemployment or some kind of assistance figured out, this is something that can be put off until it is that urgent or emergent situation. Or if you're trying to juggle having multiple children or multiple generations in your home and just keeping everyone safe and trying to get a job and just all those practical things that just become the getting through the day priority versus all the barriers to getting health insurance and understanding it and understanding the lingo and going through the multiple steps just seems overwhelming at a time when we're all so overwhelmed with sometimes just getting through the day. And it's a lot to think about too, then to have that extra, that copay, what if, can I afford that right now? I'm trying to keep lights on, I'm trying to keep food on the table. It's a lot on our families. And then if you add disability on top of it, you just keep layering those complexities and those barriers upon barriers. And so it's a very concerning time for certain.
Great. I think Vanessa might have something to add to this too.
Oh, no, I think we covered that. I think Michelle covered the real life situations that we're living in. We're not going to look at anything until our fingers falling off. Then we're going to go to emergency room, or we might wrap it up for a day or two until we say it doesn't look that bad. because coming out of the hospital with another bill that you have to look at is just an impossible thing to face. You know, it's just another thing to face.
Yeah, and I think it's a great example of something that was already there that COVID has really exacerbated for us, because a lot of families that might be eligible for some of these programs, again, we can say that as eligibility for programs goes up, somehow coverage rates go worse. So it's not a matter of just saying we have programs for you. It's a matter of the process and making it simpler. And we have to acknowledge that when we're looking at people that are eligible for these programs, they have so many other things on their plates from day one. And insurance, to a lot of folks, I think maybe this is where our marketing has failed us. It's a preventative item. It's a future looking item. It's something that takes care of something if it should happen. If you're about food on the table for today, that's a tough argument to sell on anybody thinking about the future. We've seen this with all kinds of populations for a very long time, you know, where we get things saying they're not taking up saving accounts at the same rate. Well, you don't have anything to save. It's not a priority.
We're at a day-by-day status right now. And I think that that's another reason. People are saying, what's going to happen today? And let me get through these hours today.
Right, absolutely. When you don't have the luxury of looking into the future, right? And we see a chat comment in there from Susan Joe saying, we remember we need windshield wipers when it rains, right? So in general, this is something that we've seen with coverage before, and now we've thrown a whole nother layer on our saying we've got this huge thing up front of us that we're not going to be able to look past to worry about something that isn't a today need. And I know anybody that's been maybe a member of one of these populations or actively is saying today thinking is very common when you're in a population where you have barrier upon barrier upon barrier and so many emergent needs just in your face right that day. So
Can I answer a question I see in the chat?
Yes.
Can the panelists share any information on how COVID is contributing to the rising rate of community violence? We already know that domestic violence is up. So let's go with all the frustration and social determinants that we've talked about before. That is just making a bad situation worse. We also know that reporting of child abuse is down. We know that that is not normal. And the reasons are the children, you know, now that the children are going back to school, you know, some, you know, maybe this number will change. But when we were in the thick of the pandemic, those numbers were way, way down. So the violence in the community, the domestic violence and the violence against children is a hidden factor until we open up a little bit. And now that schools are back especially for our children, maybe, you know, some of those numbers will change.
I think one of the other things related to some of those numbers is also related to the, unfortunately, opportunity and basic needs, because people are unemployed and don't have things to do or the ability to put food on the table. And so I think some of the opportunistic crimes are increasing in part, as we see related to that, but people who are just closed in and not having work or other things to occupy their time is another contributing factor to that. So I think, again, the extent to which we can get our society moving again and opening up, I think will help with some of that, and also getting people connected in a way that they are less isolated can also help with that.
One thing I wanted to add is I think that, again, COVID is shining the light on something that's been a problem for a long time, is access to mental health care. And when you are stuck at home and have all of these pressures on you that are economic, health, your life turned upside down, and you have not had the benefit of having access to mental health care pre-COVID, you're just not equipped to deal with all of those pressures very well. And then, of course, offices were closed down, services were not accessible for a while, and there's this backlog and this demand. And so that all those things just bubble up to make a pressure cooker kind of situation that's just very difficult to deal with.
Absolutely, and we know healthcare is something that's a habit, and keeping coverage is a habit, and they're also easy coverage, or they're easy habits to break. And mental health is certainly even more difficult with all the stigmas involved on top of the access to coverage, the access to a provider. You've got all the other barriers going on in your social setting and personally that make it easy to detach from that good habit there too. Excellent, excellent points there. All right, so I want to just take a step back from COVID for a little bit. Obviously, it's kind of the window we're all gazing through at the moment, right? But as we've talked about throughout, and as Cara shared in her presentation, which was pretty much all pre-COVID statistics, right? Because we can't collect great statistics now for a lot of reasons. But as we step back from that and we look at some of the barriers that are really existing and have been there for a long time and slowly been getting worse outside of COVID, you know, we have a lot of things going on in different communities. I want to look at the African American community specifically for a couple of minutes. So infant mortality, we did just announce as a state that we were at a record low level, which certainly a wonderful thing. We've put a lot of things in place. The Healthy Indiana Plan brought in HIP maternity. We have OB navigation work and services going out there, wonderful things. But we still have several times higher than any other rate in minority communities, and especially the African American community. I don't know if Vanessa, you might talk about that and talk about what's left to be done there, because we're missing our.
Oh, there's plenty to be done in this area because the numbers may look good in Indiana, but they do not look good for African American women and the infant mortality rate. You know, I'm going to do a little sidebar on maternal mortality because that is just as important. But what we know is that if we use, Indiana's got to come up with some other things. Doulas are all over the country and just now starting in Indiana. The doula is a person that assists you through your pregnancy in the first year after birth. Those ladies need to be brought into the forefront. They are doing wonderful work to help bring these babies over the finish line. So we really need to fund that program to the fullest that we can fund it, so that there are doulas all over Indiana helping women that are pregnant. But I gotta skip over here to maternal mortality because in Indiana, the rates for maternal mortality are worse than Iraq or Vietnam. 53 African American women per 100,000 died just by being pregnant. 44 Caucasian women died just by being pregnant. So that's nearly 100 women per 100,000 that are dying. And we know the reasons is first, they're not listening to women when women are telling them what their bodies are doing. We also know as far as the African American community that for some reason that they think that African American women have tougher skin. Now, we can go back, I can't remember the man's name that did gynecological work on African American women because he thought they didn't receive pain. So for some reason, that is still going on in 2020. And it doesn't matter your socioeconomic status either. You can be poor and they not listen to you, and you can be rich and they not listen to you. We know various examples of that is going on. We need to make sure that those numbers, the best thing for a baby is their mama. And a mother that dies within a year or dies having the baby is something that we shouldn't do. These are things that we had better health care for women back in the 80s or anything is better than what is going on now for women. They're not listening to us. Their doctors aren't listening to us. So that makes me move into the implicit bias and cultural competency and continuing education hours that I think that they need to be able to understand and communicate. And we communicate differently. Even if we have a different language, we communicate differently. And you gotta be able to communicate with me to understand what I'm going through. Or you cannot just make up your mind that this is what I'm going through and you haven't asked me a question. So I'm on my soapbox about maternal mortality in Indiana, and I believe, and the numbers on infant mortality moved slightly. It was like a point. So, okay, we'll tote that, but what we need is, I think we need, basically in Indiana, I think that they need to bring up and come up with more doula services, more education, more safe sleep, you know, all of those things that we had programs for 10 to 15 years ago. We need to do them again. They're there. They just need to dust them off and do them again. And that might help in Indiana, but we need a great push in healthcare workers that could make this a better for children and better for mothers. I know that we're covering kids and family, but kids aren't going to be good unless they have a good mother, and they're not going to do anything with a mother that's not there. That's my soapbox. I'm done.
Wonderful points, Vanessa. And we did have one of our participants ask about if you'd be in favor of trying to extend coverage for new mothers into the first year. So at least for the first year point.
I already have that draft. It's already done. It's already done. We get 60 days in Indianapolis for postpartum care for women on Medicaid. And I guess we talked about that there weren't that many states around the country that are doing that. They have got to do other things too. They have got to learn how to talk to their people. We found what I did was I started a maternal health caucus to bring education to the legislators, you know, because I was going to be asking for some money next year. So I wanted them to know why. That there are different areas are doing different things that are keeping mothers alive and their children alive. And I think that it's time for us to decide that we need to do some innovation for our mothers and children in Indiana. And my toolkit gives you examples of where it is, where it's being done well, and what it is. So bringing all that to the General Assembly in 2021, because we need to save our mothers, and in saving our mothers, we save our children.
Wonderful. And of course, talking about those generational habits that we can establish by getting proper care from the start. Great example of a health disparity that starts literally at birth for too many of our Hoosiers.
But we do also know that the rural areas have just as much difficulty, if not more, than the urban areas, because rural areas don't have a hospital that they can get to in 5 or 10 minutes. It's going to take, if you're in a rural area, it may take you an hour, 2 hours to get somewhere when you're in crisis. So the rural areas are just as bad as the urban areas. Rural areas have their own set of problems. Urban areas have their own set of problems, but there's still problems that we need to work through.
Excellent. And it reminds me of another discussion I want to go into, especially as we talk about doulas and the success we've seen in that model, is the on-ramps we have for coverage and care in our state. Doulas are a great example, of course, where we're saying, you know, the traditional on-ramp of, well, you know, go find out how to apply for Medicaid after somebody tells you you might be eligible, and then walk through the process. Maybe work with a navigator group like Covering Kids and Families if you're lucky enough to be told about us, or if we're lucky enough to get in touch with you ahead of time. But what are our on-ramp problems for care nationwide and in Indiana? Do we have the right welcome mat? Do we have a welcome mat? What can we be doing instead of waiting for folks to find the ways to get signed up for care? And that's open to everybody.
So I think I'll start by just going back and building off one of the things that Vanessa said, and then one of the things that you just said, Mark, in terms of you know, sort of starting at birth to some extent. And part of the issue is it's actually starting before conception. So all of the disparities that we discussed earlier in the morning, those have implications for women being able to carry a child safely and themselves surviving the childbirth process. So when you look at obesity, diabetes, all of those things for women, who, particularly women of color, Black women, higher rates, those have implications for their ability to deliver. And Medicaid, of course, starts once you get pregnant. But it's kind of hard once you put the cake in the oven, you can't clean it. So being able to do those sorts of things to make sure that women are entering pregnancy healthier, I think it has implications for better birth outcomes for both the child and the mother on the other end. I think in terms of what we do for our on-ramp right now, I think we have to approach this differently and to think about how we are reaching people at a time when they're not coming through traditional doors that we would have to reach them. So it's been interesting as we have been at home for a while now, seeing how businesses are innovating to reach people, to get their word out, to let people know about those products. And I think that we need to be thinking about similar sorts of things when our traditional channels that we typically reach people to get them the word about coverage, to sign up for them. If we can't do that, how are we adapting to meet people where they are and to get them what they need? So I think that is one of the things, and kind of partnership has always been an important piece with working to get people connected to cover, reaching, engaging with, some of the faith communities or some of the others who might be reaching out to people at this point in time and connecting with them to see if there are even just a mention that could be said, so that, if you need coverage, if you've lost your job, here's how you can get coverage to be able to get care and to think about making sure you're getting those services. So I think we have to think differently at this time and lift up how we can build some of those other pathways that are really, we're really creative when we need to be. And this is a time where we really do need to be creative to reach people where they are and to get them what they need. Because a lot of people are not going to come seek this out, as we said, when they're just trying to manage what's happening in their home or in their immediate environment.
Wonderful. So, and I'll segue into a specific instance of, I think, an on-ramp issue that we've seen in Indiana. So our Healthy Indiana plan, which has been, by all accounts, phenomenally successful, hundreds of thousands of Hoosiers signed up, a lot of good benefits there. I was actually one of the people that enrolled, one of the first people in the Healthy Indiana plan a long time ago, when I think we had just a few thousand slots available. To see a growth level is fantastic. However, no surprise that we are seeing some disparities there. One in particular that's been documented recently is the difference between sign up and retaining people on the Healthy Indiana Plan Plus versus Healthy Indiana Plan Basic. So everybody starts on Plus. If you make your small power account payments for that, you'll stay on that. You'll have co-pays, you'll have vision, dental, chiropractic benefits. And basically, economically, if you look at using it at all, it very quickly, that small, usually $5 or $10 monthly fee more than pays for itself. But we see in some communities, and especially the African-American community, it's much more likely for the folks that, even though they automatically start on HIP Plus, to get knocked down to HIP Basic. Any thoughts on what we're seeing there? That seems to relate to a lot of other trends we've seen. What are we doing wrong in our messaging? If it makes perfect sense that everybody should be better off and have a better economic picture on HIP Plus, as far as just the general cost of it, why are we seeing that disparity where a large chunk of the African-American community, much more commonly than other groups, and certainly Caucasian groups, is moving down to HIP Basic and getting that lesser level of benefits? Where are we failing? Any thoughts? And that might be a good Vanessa one again, if she wants to give it a roll. What are we doing wrong in our communication?
Say that again.
So in the Healthy Indiana plan, where we're getting a lot more African-American folks getting knocked down to the HIP Basic plan that has far less benefits, what do we think is going on where the messaging isn't matching what we're seeing in other groups that seem to understand or seem to be getting properly messaged the benefits of the HIP Plus program, we're missing that messaging with the African American community. Any idea what we could be doing wrong there?
I think that now we're just having a general non-communication issue, or education issue, and maybe the administration can the administration just put them in there, or do they have to initiate it? I guess that would be. Can't they just automatically upgrade them? Or I don't know the process. See, I really don't know the process for HIP. So I guess that I'm kind of like a person outside looking in saying, okay, I don't know why it's so difficult.
Right, and they do start on HIP Plus. If you don't make that initial payment and continuing payments to stay on HIP Plus, which again, very small, usually $5 to $10 a month, and HIP Plus pays for your co-pays and everything else. So again, if you look at the math, it makes more sense to be on HIP Plus. But we see a lot more folks, very much disproportionate to other communities in the African American community, getting knocked down to HIP Basic, which has less benefits. It doesn't have that small copay feature.
Well, maybe it's the copay. Some people just don't have that, and especially right now. Some people don't have that. That goes back to what I'm saying about a person not even looking for health, for work, for help with their health, because they're just making it work. And you know what? I go back to marketing. I go back to what is communicated. And we also talk about implicit bias in the healthcare system and communication between who you're talking to and how they're talking to you. So, I just don't know. All of that could be a factor. All of that could be a factor in not doing it.
Mm-hmm. No, and I think we keep coming back to that marketing discussion, which really, it's very much the appropriate level to look at. Are we marketing appropriately? Are we marketing appropriately to specific populations? And I grew up in a time where they thought marketing to the Hispanic population means, well, translate one billboard into Spanish and now you're good to go, right? That's language. That's part of how we communicate, but getting people interested to sign up for healthcare coverage and go through all those hoops seems like a whole lot more than speaking the right language.
And it has to be a trust issue. Are you trusting the person that you're talking to take me through the hoops that I need to go through, which also brings me back to, I work for Indiana Minority Health Coalition, that could assist in those hoops. And especially in the Hispanic Latino community, they don't trust anybody but the person that they're talking to, because first of all, they have reasons to not be trustworthy. To not trust right now. So, marketing in a language that you understand, talking to people, not talking down to them, but talking to them on their level. There's a lot of things that can be done that are just simple. That I think our healthcare system has to go through some trainings I don't know if it's all on us or if it's all on the person, or is it on the healthcare to be completely transparent and understood.
Mm-hmm.
And I would add, I think the marketing is important. I think also understanding what those challenges are. I'm sort of watching some of the chat conversation about how the application kind of works and when people have to set up the account. And one of the things that we do know is that particularly Black and Brown communities have less access to banking. So the ability to have an account that you're going to do a transfer from, if that means then you're going down and doing it through some other source which has a higher fee to transfer, then it's not simply a $5 copay that you're talking about, but it can be that $5 copay plus whatever the transfer fee is. And I think one of the things that, for us who live and breathe this, we think about, poverty and we say poverty rate and we throw that around. But I think it really is worth bringing back to bear that we're talking the federal poverty rate for an individual is basically $11,800. So you divide that by 12 months of the year, and that's not a lot of money. Or, for a family of 3, we're talking basically $22,000. So again, dividing that by 2, taking out rent, food, clothing, transportation, all of the things to keep the lights on. And it really does become a challenge. So I think understanding where are those barriers to the process and what's happening there may help to identify solutions that can help to eliminate or reduce the number of people who are being kicked off and switched over. But I think, banking is one of those. We know in communities of color and low-income communities, access to banking is a problem. So even just that ability to set up an account to transfer and not pay the fees is important.
I also wanted to add, I think a lot of our systems are set up for people who receive consistent paychecks and doesn't really take into consideration that not everyone is on a straight salary where you get the same amount of money every week or every 2 weeks or every month, however often you're paid. And so if you're looking at gig workers and seasonal workers, workers in service industries and other industries where the hours may vary from week to week, having that type of payment be due on a schedule that doesn't match with where they're getting their paychecks from might be an additional barrier that the system doesn't really take into consideration.
So wonderful points on some of the systemic issues that we have in those populations. You're right, bank accounts, that's an excellent point by itself that a lot of people really miss, because there's an assumed access when you're in a position of privilege where that just seems like a basic thing that everybody has. And most certainly it's not necessarily something we all have access to. So I want to, because we're actually coming into kind of the last quarter mile stretch here. So I want to go into some kind of quick fire questions so we can really try to get closer to action steps here, right? Because we want to make sure we leave our audience with things that we're specifically working on and working towards. So I will point out that, so the governor's office has recently at least announced a new cabinet position, Chief Equity, Inclusion, and Opportunity Officer. Our Family and Social Services Administration has opened up multiple initiatives on health disparities and looking how to address those, looking at social determinants of health and everything else. So I'll ask the super simple question for each of our panelists to chime in and answer on, which is, what is day one thing that you'd like to see done through any of those things? Do you have the ability to make something happen that you think would be the right way to prime the pump to really get us moving on tackling these health disparities? And don't worry, Cara, you're not off the hook, because we know you can talk federal too, so you can get on that one. Do you want to start, Vanessa, do you have anything? What's your day one?
Job description first. What does that entail? Are you just giving the title and letting them come up with what comes up, what they do on the inside? I've heard of this, but I don't know what that entails. So first, I mean, do we hire you on day one and then you come up with your job description, or what milestones are you supposed to meet? Where are you supposed to go? What markers what is your end goal? What are you trying to get to? Do you know where you're starting? So those are my general questions.
Great. Let's pick on, let's see, Michelle, what would you like to see? What's a first health disparity you'd like to see addressed?
I think that enforcement of current legislation that's already on the books in terms of federal mental health parity law, state mental health parity law, non-discrimination, Section 504 from the Rehabilitation Act, making sure that the existing laws that we have on the books are being enforced, and that our Department of Insurance and other regulatory bodies have the power and the staff and the funding to do that. I think that would be one of my top priorities for that job.
Oh, great point. So yeah, starting off with 1, make sure we have a job description, and 2, make sure we're actually addressing what we're supposed to already be doing. Excellent points. We don't want to just gloss over that part of it. Kosali, what do you have to add there?
I think I would just add to what Vanessa and Michelle have brought up as saying that metrics are really important, because if you're going to be having the job description and thinking about what you're aiming for, how do you know when you've gotten there? So that also helps identify what may be the lowest hanging fruit that go after first and say what with the simplest actions might reduce disparities the most. We won't know unless we have really good metric systems.
Excellent. And Cara, what do you think? And you can pick state or federal. What are good first actions to be taking here?
Yeah, so I think I'm going to build on what each of my colleagues have said. And I think accountability in resources. So the job description is great, but also a budget to be able to carry out the work is critically important. And the accountability is not just on that individual, it's actually on everyone in the department and across the state to make sure that we're thinking about how do you embed a focus on equity across all of the work, because it's there's no way one person or 5 people, if you make it an office, are going to be able to do that work. It really is across everybody thinking about how do you engage and how are you thinking about that. The other thing I would say is establishing a process to make sure that community is involved at the beginning, implementation, and the evaluation of the programs to make sure that in the design it's going to work in those communities and that we're sharing them and bringing them to the table, because very often they're not at the table when these conversations are happening.
Tremendous answers, everybody, on that one. So, okay, moving on to part 2 of our lightning round. I love that we're all thinking systemically on this, and we're not just jumping ahead and saying, "Well, here's the one thing to jump right into." We've got to have the right backbone behind it. So, next question. I feel we really have to, because there's no way we could possibly today dig into all the disparities and all the populations affected by disparities. But is there a particular group or population that we haven't covered today that you just want to take a minute to shine a light on, that's maybe not at the forefront of some of the discussions that we're having right now today or in general in our country? Who comes to mind as somebody who's kind of a forgotten disparate group that we really need to start looking at? And again, we could start again with let's say Michelle, what do you have for us?
I think I've been particularly thinking about members of the disability community who are nonverbal or minimally verbal, and just how that really impacts their ability to participate in their own care, but also really impacts the way that they're perceived and the way that they're valued, not only in society, but also when they do access healthcare. Not treating them as participants in their care and decision makers in their care, as opposed to taking what's more the easy way out and using sedation or using chemical restraint or things like that, and just really doing a better job of using the behavioral tools that we have at our disposal to work with nonverbal and minimally verbal people to be able to communicate and to receive information the way that's best for them, and to be participants in their care and in their own lives in general. I think we tend to push them to the side and focus on other parts of the disability population because they are verbal and they can advocate for themselves, at least in some way. So I'd like to see that.
Wonderful. Let's see, Kosali, who do you have for us that we're not really paying enough attention to?
No, I was giving this some thought while Michelle was talking and thinking, there isn't one area I could come up with, except to say that thinking about these disparities from a community level seems particularly important, because we've had a lot of discussions that are at individual levels, but really it's that one of the reasons we might be having this discussion about inability to pay these HIP plus payments is not just one's own resources, but the community that you're in. So we have there's housing segregation, there's ways that we are in geographic spaces where we don't have people near us, whether it's family or friends, to whom we could turn to as that social safety net when needed. So we really should think about strengthening the community level disparities as well when we think about the individual ones as well.
Wonderful. Vanessa, what do you have for us? Who are we forgetting about in these discussions, or what specific population really needs some more attention?
I think that all populations are not getting more attention, the attention that they need. And I think that community organizations that are on the grassroots level are also being ignored because they can do the work. They know the people. They speak the language. So, you know, I believe what Kosali said. I believe what Miss Michelle said, but I believe that the administrations have come up with great ideas, but then they don't go and ask the people that have to implement them what the problems are in implementing it. So I kind of see the cog in the wheel on the level between administration and grassroots, and not recognizing that grassroots people can go in and make things a whole lot smoother for you. And the administration, they don't see it. You know, they see their idea, they want you to, and they want to implement it. I guess my best example is the translation service on contact tracing right now through COVID for the Hispanic population. It's not working at all. So it could work if you use those organizations that are trusted by that population to get the work done. So I think about it altogether different. I think the administration should look for the community to help them, and those community organizations that have the pulse of the community. Ask them what they need and how to get it. Because a lot of times the administration comes up with a good old ideal on their own. Yes, we're going to do this. And then when it doesn't work right, then they go, well, what did I do? You didn't ask community whether it was going to work. So that's where I'm at. You know, I think that all people, also I see in the chat, yes, undocumented people are not going to seek help because they're scared. I'll give you one small example. We know that in a northern town that they were setting up COVID testing, and who was over the COVID testing took upon themselves to be rude and mean to undocumented and scare undocumented workers. I mean, undocumented people that were trying to get tested. So it stopped. They stopped and they didn't go to this person anymore. They had to literally shut this person down because of the damage she had done, like a lightning wave through the community. So administration, choose somebody that is trusted by the community to help you get what you need, and marketing. Okay,
Great answer, Vanessa. So, and I see that we are getting close to our time, so I'll warn our audience we might go just a click over because I want to get to one more question. But so, Cara, for you, one population that we're really missing?
Yeah, so I'm not going to expand on these a lot so that I can say quickly what I'm thinking. I will lift up that in the chat, someone also mentioned the Burmese population. And I think that, you know, I'm going to say a couple of them. Older adults, we're not really talking about them. Tribal communities, I know that's not a huge population in Indiana, but tribal communities, we are missing the boat on what's happening in there, and it's really an issue. Men, and we don't talk about men in Medicaid, but men are, you know, really important in a lot of spaces, have some unique challenges. We focus a lot on women's health. We're not talking about men and some of how they're navigating through this time. And I would lift up the homeless.
Wonderful, wonderful. We know there's plenty more, and I'll have to add my own super quickly, but sexual orientation and gender identity, we don't even have the research. We're not even doing overlays of mapping their statistics against other statistics we're talking about today. We're just starting there, and it's probably overstating to say we're starting because I'm not sure if we've started. So I have to chime in there and say that's definitely a group that we've got so much to do there as well. Okay, so super quick because we're getting down to our last few minutes. But what I will ask everybody, because we want to leave things on a positive note if possible, so lightning round style, I want everybody to think of one specific thing that each person listening today can do, one direct action. And we'll start with Vanessa.
Well, you know, I can do my job and come up with some legislation that would help the community and the children and everybody involved. You know, I have some legislation especially the maternal mortality postpartum care for women past 60 days. There's pregnancy accommodations for women after they're having their baby, and doula services that would help bring healthy babies into the community.
Okay. So I'll take that as one, our audience, talk to your legislators about those issues, elevate those issues.
Know who your legislator is. And if you want an advocacy on how it's worked to do it, call me. I have one already ready. All we got to do is do it.
And I guarantee she's serious, folks. So if you're listening, that's not it's not an empty
I've
promise.
got an advocacy workshop ready to go.
All right. All right. So next on line, Michelle, what do you have for us? What's a good take home for our folks?
I think whatever role that you play in healthcare and in your community, constantly ask those you're interacting with, is this equitable? Are we forgetting anybody? And just being intentional about that and making that a constant part of the conversation. Is this equitable? Who are we missing?
Wonderful. Every conversation needs that. Kosali, what can our folks do?
I would say stay informed, make sure you're watching what's happening and then acting upon it in the ways you've heard. I think it's a joint community responsibility to ensure these disparities don't hold back potential.
Wonderful. And Cara, take us home. What's your take home for everybody listening today?
So educate yourself on the disparities in the area that you're engaged in and who the players are who've been working in those space, and develop partnerships with them. Develop a plan of action to tackle one disparity. It doesn't have to be that you try and do everything, but the journey of 1,000 miles begins with a single step. Take that step and we can get there, and partner, partner, partner.
Wonderful. So I have to thank everybody for just such a great discussion today. We could be going for the rest of the day. I have absolutely no doubt of that. A great panel. So thanks to you all for being a part of this. Cara for presenting our keynote there as well. And certainly I want to end with my take home after thanking our attendees for joining on. Again, great numbers coming through, great questions through the chat. Everybody find your path to get involved. Listen to the points the presenters came up with. Of course, covering kids and families, just as Vanessa offered, you can call me and bug me anytime too about how to get involved with policy here in Indiana. I will walk you down to the State House. We can get you there and get involved. We also have our policy committee and some other things involved. So we'll have a slide coming up in just a second with contact information for everybody here and the different ways to get involved. And really just want to remind everybody out there that's hearing this conversation today, most of all, mask up, stay safe. And if there's one point I'm going to make the take home for everybody, get out there and vote. It's the one right we don't use enough, and we need it from everybody. So greatly appreciate that. And that's my comment, as well as a lot of the comments in the chat as well. So we all have ways we can get directly involved. I don't want this conversation to end today. So thanks again to our panelists and our attendees. And again, we'll be getting some information up here shortly, so you can contact anybody that you'd want to in addition after today. So thanks everybody, and we hope to see you involved with all these efforts ongoing throughout the year.